Hi there, welcome to our pharmacy revision series. Today we're going to be presenting a video on methotrexate, an potential OSCE situation, question on calculations, and also a single best answer in your pre-registration question as well. So the OSCE situation is something that you may face or another similar situation, and we're going to be talking about how you would deal with this type of case study. So you have a patient that presents into your clinic, they have to be started on methotrexate, you have reviewed their medication and clinical conditions, there are no counterindications. Counsel the patient on the following: the monitoring they need, any symptoms they need to look out for, key drugs they should avoid. Okay, so this is a very basic one which cements all your knowledge together, which you should really learn in year 2, 3, and 4. Okay, so we've got immunosuppressant medication. So this kind of links in with this cycle of toxicity, side effects, hospital admissions. So what kind of medication would we be thinking of? So let's look at immunosuppressant medication you commonly see dispensed: azathioprine, methotrexate. Sometimes cyclosporin is also dispensed as well. Patients may have a transplant, they are dispensed things like mycophenolate, tacrolimus. Okay, it's really worth that if you do work in practice or you're observing practice as well, that any hospital prescribed medication is recorded on the notes as well. Now, let's look at this scenario. So we're going to presume that the patient is prescribed the medication from the hospital. It's been started by the consultant, got this shared care agreement. So for those that don't understand what I've just said there, certain medications are started by a specialist, patients are stabilized, and then there's an agreement with the prescriber in general practice, in primary care, that actions they need to take when they prescribe that medication. That documentation is signed by the GP or the responsible clinician, the consultant and the patient. They enter into this agreement. So methotrexate is monitored every 12 weeks for patients to have blood. So we're reviewing signs to see if there's no toxicity, especially liver toxicity. So patients will have things like a full blood count done, U&E done. They will also have an LFT done, which is a liver function test. We will go through blood tests in a later lecture. They'll have those every 12 weeks. So if you're getting an opportunity in pre-reg, or you're working in a GP practice on a placement, it's really worth asking about the pincer searches or how they monitor methotrexate. Next, we talk about the counselling points from the BNF. Obviously, we talk about things such as blood disorders, sore throat, bruising, mouth ulcers, liver toxicity, nausea, vomiting, abdominal discomfort, and dark urine, respiratory effects, shortness of breath. Because obviously the way that methotrexate is, there is the interaction with NSAIDs. So over the counter, you would not sell NSAIDs, you would not obviously sell aspirin or ibuprofen. Now, sometimes patients may be co-prescribed NSAIDs. That's agreed by the GP or the specialist for a short term. Obviously, if a patient's on aspirin, they've had an MI, and obviously they're taking methotrexate, that is reviewed, and sometimes that is long term, but the risk is obviously OTC. That shouldn't be done there. Now, your next thing is, we've got our next OSCE case study, something that you commonly would see, a scenario here. Patient MF is 68, 49 kg, they have hypertension, rheumatoid arthritis, COPD. They presented to the pharmacy, the dose of methotrexate has increased and they have a sore throat for the last few days. So you need to talk, so obviously you've got the medication history there, and the dose of methotrexate was increased 1 week ago. What do we do in this situation? So obviously blood disorder is going to be straight to A&E. That is a red flag. We will be going through red flags in greater depth and a lecture on this, associated both with OTC and from obviously a monitoring perspective with the different kind of drugs, both therapeutic drug monitoring and also drugs that cause immunosuppression as well. Now, obviously, with this being a red flag, you'd refer the patient straight to A&E. You get probably choices. You may get a question there to say, oh, what about going to the GP surgery? This is looking at blood disorders, maybe a sign of toxicity. The patient needs to have those blood tests, and then obviously they can be referred appropriately. This is what you would do in the scenario. And the thing is, if you said something else, you would get marked for this, because this is a red flag issue. So it's really, really important that you understand when to refer in that red flag. So obviously, if it does say patient care advice to look out for the signs of toxicity, A&E, easiest thing to do. You then obviously understood that it's a red flag. Next scenario you get presented with calculation questions. So typical questions would be your medicines optimization, pharmacist and GP practice, organizing repeat prescription for patients. Your practice has started a 2-month repeat prescription program for patients. In some areas, it's 3 months. Patient GF has commenced methotrexate 2.5, 15 milligram once weekly. What is the total amount of tablets you need to prescribe for 2 months? Simple question. So obviously 6 tablets a week, 24 tablets a month, 48 tablets for 2 months. Other calculation questions you can get for just counting tablets are things like amiodarone. So if a patient starts on 1 daily, then 2 daily, they start on the loading dose of amiodarone, and then obviously they go into the maintenance dose. So they start on 3 daily, 2 daily, then 1 daily. Okay, things like that. And prednisolone, you talk about the dose reduction there as well, dose reduction, weaning regime, those kind of things come up. Now, single best answer question for your pre-registration pharmacy exam. A patient presents to your pharmacy for a prescription of methotrexate 10 milligram tablets, newly diagnosed with rheumatoid arthritis. They take sertraline and clodimol, no other medication. What action do you need to take? Dispense the prescription to the patient, return the prescription to be changed to 2.5, advise the patient you can't dispense this due to a drug interaction, advise the patient you need to have the blood test results before you dispense this, and check the patient needs appropriate counselling advice. Please, 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 with anything to do with methotrexate from a community perspective, or even just bordering a pre-registration perspective, 2.5 milligram tablets once weekly with both the dose stated. So, for example, methotrexate 2.5 milligram, 1 tablet, in brackets 2.5 milligram to be taken once a week and even on the specific day as well. Okay, really, really important here. Next slide we're going to show you is the NPSA advice you've got here. So all specialities, including hematology, should prescribe methotrexate dose in multiples of 2.5 milligram, 2.5 tablets, and total dose in milligrams must be included. Okay, as explained before, methotrexate must not be prescribed or supplied. So for certain conditions, you do have that methotrexate 10 milligram tablets there, but for your exam perspective and looking at your OSCE perspective, 2.5 milligram once weekly. We've talked about the label, and obviously the key bit of information here also is a drug interaction, cotrimoxazole and trimethoprim. Absolute contraindication, must not be prescribed under any circumstances at all. Okay, so with methotrexate, it's really important that obviously you understand that that's a once weekly dose. You're doing 2.5 milligram tablets as well, and a lot of CCGs and obviously GP practices audit this regularly to ensure that patients get that 2.5 milligram tablet. Sometimes you may get an OSCE situation where you get a patient on methotrexate 10 milligram tablet and ask to clinically check it. First thing, reason rationale would be it has to be as per NPSA warning alert, 2.5 milligram, and obviously the dose has to be once a week as well. We're going to be doing more things around in drugs on immunosuppression, kind of OSCE situations that you face as well. Please put in the comments box if you want us to cover any other kind of drugs that you are thinking of with your OSCE and your revision. And then obviously we can make those as part of our revision series as well. Thank you very much for listening to this presentation by CBH Education. Further information on drugs, pharmacology, OTC medication, OTC products, the legal aspects of prescribing, and further OSCE situations, please follow us on our Facebook, YouTube, and Instagram channel.